Assalamu alaikum. Good morning, everyone. It's Dania, and today I'll be talking about the scheme for upper limb fractures. This scheme will be used in the following videos to summarize all of the fractures in one tape. So, for each fracture, we'll talk about the site, the incidence, whether it's more common in females or males, in which age, the etiology, whether trauma, direct or indirect, and usually the most common indirect trauma causing fractures is fallen outstretched hand. As you can see in this image, fallen outstretched hand has resulted in multiple fractures in different parts of the body. That's why it's usually present in our comparison with all of the fractures together. Uh, Concerning the clinical picture, we will talk about the symptoms, pains and swelling and limitation of movement. The pain will be presented as tenderness and swelling, limitation of movement as signs. However, we have three short signs of fracture as deformity, neurovascular affection, crepitus, and bone shortening. For example, the right hand will be shorter than the left hand. We will also talk about the displacement, and the basic investigation is usually X-ray, anteroposterior and lateral view, and for some certain indications we will order a CT. For the complications, we will talk about scheme, but before going on to the complications scheme, we will start with the treatment. For sure, if the patient is a polytrauma patient, we will start with A, B, C, D, E, and then we have either to do close reduction with external fixation or open reduction with internal fixation. Open reduction with internal fixation is usually indicated if there is pathological fracture, unstable fracture, neurovascular affection, irreducible fracture, or soft tissue injury, and most simple indication is open fracture. The bones open or compound fractures, so open reduction must be done. What about the complications? We have the five main general complications, 3S and 2Ps. First of all, shock. Either hypovolemic shock due to blood loss, if this is a polytrauma patient, or neurogenic shock from the pain. Second S is stiffness. Number 3, syndrome, which is crush syndrome. Release of myoglobinuria causes acute renal failure. Number 4, prolonged recumbency, which can also result in paralytic ileus. And 5 is pulmonary embolism, which is more common with fracture femur. This is for the general complications. What about the local complications? We will summarize the local complications into complications in the bone and complications around the bone. For complications in the bone, we have malunion, which means that the bone will be joined or healed in non-anatomical position. Non-union, the two parts of the fractured bone will not heal together, or delayed union, in which union will occur and it will be proper repair, however it will not occur in the proper time. Number 4 is infection of the bone, and 5 occurs with the joints, which is Sodix atrophy, and we will talk about Sodix atrophy in a separate video. What about other complications? Complications around the bone. First of all, the skin, there will be either skin injury or skin infection. For the viscera, there might be fracture of the pelvis, resulting in injury to the bladder or urethra, and it may cause injury to the ureters in females. This depends on the extent of the injury. Number 3, for the muscles, we have myositis ossificans and Volkmann ischemic vasculitis. And again, we will do a separate video talking about myositis ossificans and Volkmann ischemic vasculitis. Number 4 and 5 are neurovascular injury, vessels injured and nerves injured. And this will depend on the anatomical level and which bone is injured. First of all, we will start with clavicle fracture. As you can see here in this diagram, clavicle fracture, subclavian vessels are injured and the brachial plexus is injured. Moving a little bit downward, shoulder dislocation, especially anterior shoulder dislocation, there will be axillary artery injury and axillary nerve injury. There might also be injury to the musculocutaneous nerve, which is a branch of a nerve. There will also be proximal humerus injury. This may cause axillary nerve injury and injury to the circumflex nerve, which is the branch of the axillary nerve. shaft of the humerus fracture, there will be entry to the brachial artery and the radial nerve, which passes in the spiral groove in the posterior part of the humerus shaft. Moving a little bit downward and supracondylar fracture of the humerus, again the brachial artery is entered, and here there might be entry to the three common nerves of the upper limb: medial nerve, radial nerve, and ulnar nerve. Usually the medial nerve is the most commonly injured nerve. What about the deformities that will be presented in our clinical patients injured with any nerve entry? First of all, medial nerve entry, there will be loss of sensation in these yellow areas, lateral 2/3 of the palm, palmar aspect of the lateral 3.5 fingers with their dorsal terminal phalanges, and this will result in a certain deformity, which is a pan deformity. Some motor tests will help to diagnose medial nerve entry, such as counting finger tests and pencil tests. Concerning the ulnar nerve, the affected area with sensory loss will be the red area, in which there is medial 1/3 of the palm and the dorsum of the hand, and affection of the palmar and dorsal aspect of the medial 1.5 fingers. This will result in partial claw hand, and the motor tests are cord tests and Frommens tests, and you will go through these motor tests in OSPI files. Finally, the radial nerve, which results in rest and finger drop, it affects and results in loss of sensation lateral 2/3 of the dorsum of the hand, especially the snuff box, which is this area. And a simple motor test is to ask the patient to extend the thumb. So this is the end of our general scheme, and thank you so much.